Good afternoon, everyone. Today we are continuing with the chapter 11, part 2, which looks at public health enemy number 2 and growing physical inactivity. By the end of this part, you will understand why physical inactivity is now ranked among the leading actual causes of death and what public health is doing and struggling to do about it. Last lecture, in part 1, we spent a lot of time on poor diet. Let's pivot to the second major pillar of this chapter, physical inactivity, starting with why it matters for weight control specifically. Physical activity and health. Research consistently shows that the most effective approach to weight loss combine dieting with physical activity, not diet alone. Why? Because physical active dieters are more likely to lose fat while preserving lean muscle mass. This matters of two reasons. The reason number one, it produces a healthier body composition, a lower waist to hip ratio. Reason number two, it helps people avoid the frustrating weight loss study that pure calorie restriction often produces because lean muscle burn more calories than fat does. Interestingly, exercise alone without cutting calories is relatively inefficient way to lose kilos, but it still meaningfully improve waist hip ratio and overall health. Beyond weight control specifically, physical activity has a much broader impact on longevity. Let's look at the evidence. A landmark study, Harvard alumni study, almost 17,000 male, those who engaged in vigorous activity for 3 or more hours per week were less than half as likely to die during the 12 to 16 years follow-up period compared to those with the lowest activity levels. Even more encouraging, among alumni who were sedentary at the start of the study, those who took up moderate sport activity at any point during follow-up had a 23% lower death rate than those who stayed sedentary. The takeaway is genuinely never too late to start. Let's zoom in specifically on a cardiovascular disease, where the evidence for exercise is especially strong. The Frenham study, dating back to 1970s, found that both men and women who were the least physically active had the highest risk of dying from cardiovascular disease, with the risk decreasing as activity level increased. So the exercise protects against both heart disease and stroke. And several studies have found that inactive men and women are more likely to develop high blood pressure in the first place, while moderate intensity exercise can actually help lower blood pressure in people who already have hypertension. What's actually happening biologically to produce these protective effects? Let's look at the mechanism. One major mechanism is cholesterol. Exercise training tend to rise level of high density lipoprotein, the good cholesterol. High density lipoprotein, this good cholesterol, often called good cholesterol, and remarkably, even a single episode of physical activity has been shown to improve blood lipid balance of several days afterward. By lowering blood cholesterol, the total blood cholesterol, exercise protects against atherosclerosis. And this has even been demonstrated in monkey studies, where exercise provided a protective effect even when the animals were fed a diet high in cholesterol and fat. Other cardiovascular benefits include lower blood pressure, improved blood flow to the heart muscles, and reduce tendency of blood to form clots. Cardiovascular disease is not the only condition exercise protects against. Let's talk about diabetes. Physical activity appears to be an independent protective factor against type 2 diabetes, meaning it helps even beyond its effect on weight. This matters enormously because diabetes is now the seventh leading cause of death in the United States. And that's likely an underestimate, since many cardiovascular deaths actually have diabetes as an underlying cause. Both the nurses' health study and physicians' health study confirm that regular exercise reduces the incidence of type 2 diabetes, largely by increasing the sensitivity of muscles and other tissues to insulin. Beyond cardiovascular disease and diabetes, there's also emerging evidence linking exercise to cancer prevention. There's evidence that physical activity offers protection against cancer, most strongly for colon and breast cancer. Some studies also suggest a possible protective effect against lung, prostate, and uterine lining cancer. And for people who have already been diagnosed with cancer, exercise has been shown to improve both survival rates and the quality of life. Given how much benefit we are describing, you might wonder how much exercise is actually recommended. Let's look at how the official guidelines developed. In 2006, the Department of Health and Human Service, together with Institute of Medicine, decided to create formal physical activity guidelines modeled on the process used to develop dietary guidelines. An advisory committee, scientific review, public meetings, and publish report. The first physical activity guidelines came out in 2008 and they were revised into second edition in 2018 based on updated scientific evidence. Let's look at what those current guidelines actually recommended. For children and adolescents, the recommendation is 60 minutes or more of physical activity every day. For adults, it's 150 to 300 minutes per week of moderate intensity activity or 75 to 150 minutes per week of vigorous intensity aerobic activity. And here is an important nuance. Adults gain additional benefits from exercising beyond those upper threshold. There is not really a point of diminishing return with normal range. Also, adults should also do muscle strengthening exercise at least twice a week. For older adults or people with disabilities or chronic conditions, the guidance is simply to do as much as they able. In consultation with their doctor, maybe is better choice or the best choice. What does moderate versus vigorous activity actually looks like in practice? Let's look at the next table. This table gives concrete examples of each intensity level. Moderate intensity include things like a brisk walking at 2.5 miles per hour or faster, recreational swimming, easy cycling under 10 miles per hour, doubles tennis, active yoga, uh, dancing, general yard work, and water aerobic classes. This regarding moderate intensity. What about vigorous intensity? Vigorous intensity includes jogging or running, swimming laps, single tennis, cycling over 10 miles per hour, jumping, heavy yard work like digging, and so on. This table is useful. This table is useful for helping patients or students translate abstract minutes per weeks targets into activities they can actually picture doing. Given these clear guidelines, how well are Americans actually meeting them? Not well, unfortunately. According to 2016's National Health Interview Survey, only 26% of American men and just 17% of American women met the aerobic activity guidelines and the muscle strengthening guidelines. That's mean the large majority of American adults are falling short of these evidence-based targets. One factor that's been heavily studied as a driver of physical inactivity, especially in children, is screen time. Let's look at that. Screen time and childhood obesity. The American Academy of Pediatrics issued updated media guidelines in 2016. lowering the recommended screen exposure levels compared to prior guidance. For children under under 18, the recommendation is to avoid screen media entirely except for video chatting. For more for 18 to 24 years, screen time should be limited to high quality programming watched together with an adult who help the child understand what they are seeing. For age 2 to 5, screen time should not exceed 1 hour per day, and again should be high quality programming only. For age 6 and up, the guidance shifts to consistent parental limit, making sure screen time doesn't crowd out adequate sleep, physical activity, and other healthy behavior. What does the actual evidence show about the relationship between screen time and obesity? American children age 8 to 18 average a striking 7.5 hours of screen time per day. In California trial, among third and fourth grades, researchers cut TV viewing time by half to a third over 6 months and found this significantly reduced body mass index compared to a control group, direct experimental evidence, not just correlation. And a broad 2019 research review found that children with more than 2 hours daily screen time were significantly more likely to be overweight or obese compared to children with less screen exposure. Now, let's turn from understanding the problem to examining public health strategies for promoting physical activity. Just as with diet, the most effective strategy for promoting physical activity applies the ecological model, combining individual level motivation with environmental and social level interventions. One honest caveat here, because rigorous long term research is genuinely difficult to conduct. Most existing studies only measure short term changes in exercise behavior. There is a very little solid evidence that any single program has achieved long term success increasing physical activity across large populations. This is an area that still needs a lot more research. One commonly proposed strategy is having healthcare providers counsel patients directly about activity. Let's see how well that works. Many organizations and federal agencies recommended that healthcare providers counsel patients on physical activity as a routine part of care. But the evidence on whether this actually motivates people to exercise more is genuinely mixed. Counseling practices vary enormously among primary care physicians, ranging from a brief passing recommendations to a formal referral for intensive counseling with health educators. What does show somewhat stronger effectiveness are community wide campaigns that combine improved access to places for activity, group goal setting, skill buildings for incorporating activity into daily routines and social support. Beyond counseling, the physical environment itself is often the biggest obstacle. Let's talk about that. The suburban car dependent American's lifestyle is described as a major barrier to physical activity and one that's genuinely hard to overcome through individual level interventions alone. In response, some communities have built walking trail or or persuaded shopping malls to open early specifically for a mall walkers. The text also points out that schools are usually underused community resources for recreation. School facilities often sit unused outside school hours when they could support community physical activity. Sometimes small environmental nudges can have an outsized effect. Here is a great example. Sorry. In one study, researchers placed signs near an escalator reading stay healthy, save time, use the stairs. This simple intervention increased the percentage of people choosing to take the stairs from 8% to 17%, more than doubling stair usage with nothing more than a sign. This is a great illustration of how low cost environment cues can meaningfully shift behavior without requiring any deep individual motivation. Beyond signage, wearable tracking devices have become an increasingly popular behavior change tool. Let's look at the pedometer and fitness trackers. The general recommendation for healthy adults is about 10,000 steps per day, roughly 5 miles or 6 kilometers, which actually exceeded the federal minimum of about 150 minutes of moderate activity per week. For less active individuals, the recommended approach is to first measure their current baseline step count, then gradually increase toward that goal. A 2007 review of pedometer effectiveness found that people who wore these devices increased their daily steps by about 27% on average and also saw significant reduction in body mass index and blood pressure. Newer devices like Fitbit and Apple Watch, like here in the photo, offer similar tracking but are more expensive and tend to appeal mainly to people who are already motivated to exercise rather than reaching less active population. Given the challenges of changing adult behavior, where does public health see the best long-term opportunity? focus on children habits. Many public health advocates believe that the best long term hope for increasing population wide physical activity is to build good exercise habits early in childhood and adolescence. Most young children are naturally physically active because they simply enjoy movement and play. The challenge is preserving that as they age. Two practical strategies stand out: encouraging outdoor play and encouraging active community, specifically walking or biking to school. Let's look at the data on that second strategy: active community to school. According to the CDC, in 2014, School Health Policies and Practices study, in 62% of school, 10% or fewer students walk or bike to school. Only 23% of school do. 26 or more students do so. This represents a dramatic decline from 1960, when 48% of children walked or biked to school. Interestingly, schools with higher active community rates today are much more likely to have crossing guards, bicycle racks, and promotional materials encouraging walking or biking, suggesting that these are genuinely modifiable, low cost intervention, not just reflections of neighborhood demographics. Now, there is analysis in 2005, analysis made striking and at the time controversial prediction that rising obesity would cause United States life expectancy to actually decline in the future. I mean, and that the next generation could become the first in modern history to die younger and sicker than their parents. Looking back now, the text notes this prediction seems uh, seems prescient. United States life expectancy did in fact fall over the 5 years ending in 2018. Rising obesity rates likely contribute to a slowdown in what had been positive heart disease trends, which was a key factor in that decline, alongside the other major drivers: death of despair, meaning drug overdoses, alcohol related deaths, and suicides. Beyond life expectancy, obesity carries an enormous direct economic cost. Let's look at those figures. Treating diseases caused by overweight and obesity is estimated to account for as much 20.6% of total United States medical expenditure, reaching roughly 119 190 billion US dollar annually during 2000 to 2005 period. Roughly half of these costs are paid through public programs, Medicare and Medicaid, with the other half split between private insurance and out of pocket individual spending. This underscores that obesity is not just a personal health issue, it's a massive shared economic burden. When lifestyle and policy interventions are not enough, medicine has more direct options. Let's look at bariatric surgery. Bariatric surgery. Bariatric surgery involves reducing the size of the stomach, either through gastric band or by surgically removing or bypassing part of the stomach. It has shown to be effective both for weight loss and for controlling diabetes in obese patient, in morbid obese. The NIH, National Institute of Health, suggests it may be appropriate for individuals with body mass index of at least 40 or body mass index of 35 combined with serious coexisting condition like diabetes. That said, there are real surgical risks involved. Patients need to be prepared to make lasting lifestyle changes afterward, and some patients do regain some of the weight they lost. Short of surgery, what about pharmaceutical options? Let's look at the history and current state of weight loss drugs. Historically, the FDA has been quiet cautions about approving weight loss medications, largely out of concern of side effects. The cautionary tale here is fenfone drug combination from 1990s that had to be pulled from the market after it was found to cause heart valve damage and pulmonary hypertension. More recent, though, the FDA has concluded that obesity has become such a serious public health concern that pharmaceutical approaches are genuinely needed, even if they cannot be entirely risk free. In 2012, it approved two new drugs: Belvic, which work by activating a brain region that controls hunger, and eczemia, a combination of an appetite suppressant and drug originally approved by for epilepsy and migraines. There is also an older drug, Orlistat, and this is popular, especially here in our region, which works by blocking absorption of dietary fat, approved at lower dose for over-the-counter sales as a lay. It can cause an unpleasant gastrointestinal side effects and, in rare cases, liver damage. We have covered a lot of ground. Now, let's begin in a conclusion, starting with the conclusion number one. Physical activity protects against cardiovascular disease, diabetes, and some cancer, in addition to helping control weight directly. People who are physically active simply live longer than those who are inactive. And yet, as we saw, Americans get Far too little exercise. This is a major ongoing contributor to obesity epidemic. As with diet, the most effective public health intervention for promoting activity apply the ecological model, combining individual and social motivation with the removal of the environmental barriers that make activity difficult. And finally, let's close with the theme that ties this entire chapter together, the importance of focusing on children. Because changing establishing adult habits is so difficult. The best long-term hope for improving population health behavior may lies in focusing on children. Childhood obesity prevalence continue to rise in the United States and other countries, but we do have evidence that family-based intervention can be effective in reducing it. Physical strategies include encouraging outdoor play, active community to school, and the quality physical education program that build skills children can carry into adulthood. And one of the single most important obstacle standing in the way in screen time, which both promotes physical inactivity directly and process children to a steady stream of advertising of non-nutritious food. That's good note to end on because it connects both halves of the chapter, diet and physical activity, through one shared modern behavior. That's conclude the chapter 11. Thank you for your attention and see you in the next chapter. Goodbye.